All right, good morning, Delaware. Thank you so much for that warm welcome, and really that the comments made by the Secretary are some of the things that I'm going to be hammering home this morning to set us off on this journey that hopefully will be transformative for when we walk out of here. We're going to do something different. So my goals today are to talk about why we should care more about women's health, why we need to do something different to get different results for the sake of our nation, what we need to do and with who, and to highlight some current local and national initiatives that are doing this differently. All right, so again, highlighting the uncomfortable truth that the U.S. spends more money on healthcare than any other country in the world. In spite of this investment, the U.S. is not the healthiest nation in the world. Long-standing and pervasive inequities in health outcomes exist across communities, especially for people of color, in order to get different results, because this is not new. We've been looking at these same results and outcomes for decades. We're going to need to do something different. We have to see the problem and think differently. All right, so this is the graph that I'm sure we've seen before. This is healthcare costs per capita for the U.S. compared to many other developed countries, and total expenditures of healthcare for GDP. And as you can see, that the U.S. is the top, way different than many other countries, and we're rising fast. Looked at differently, so what is the outcome? Life expectancy based on how much we spend per capita. The U.S. is on the far side of this graph, really far away from everybody else, and we're actually on the lower side of life expectancy compared to some of those other countries. You think about that we have almost similar life expectancy as Panama, and they spend about 10 times less. And we're getting worse. So in 2018, our life expectancy is going down. The U.S. has more illness and disease than any other of the countries, and yet we have the highest rate of deaths amenable to health care. We're spending a lot and getting less. So, more than a century ago, this quote is at the bottom of an email tagline from Mary Kay Moose, who I consider a mentor and friend and one of the mothers of preconception health. Few things are more important to a community than the health of its women. And if we look at our statistics, this is probably where our problem lies, that we have not been focusing on the health of women. And the statistic that the Secretary already mentioned is the most sensitive statistic that we have, infant mortality, to demonstrate our commitment to social welfare is the infant mortality, and we're not doing good there either. So here's that graph. So infant mortality, the United States is the dotted line here, and you can see that we actually have started to lag behind. We were doing better than countries such as Hungary or Cuba a few decades ago, and now even they are doing better than us. We're 55th in the world. What that puts us around is countries like Serbia and Bosnia and Herzegovina, places that have experienced war and famine. All right, so it wasn't all bad news. We actually are improving. So there was a brief that said we've experienced a 15% decline in infant mortality over a decade. So that was actually hailed by all of the press groups. We're doing great in the United States. We're getting better. And actually Delaware, it was just mentioned, you improved that. That was a 19% improvement. However, your rate is still higher than the national rate, as already mentioned. So, however, when we look at the statistics, this rate really was driven by SIDS deaths rates, which is really good. So fewer babies are dying from SIDS. The preterm birth rate actually went up. And preterm birth, we know, is a key driver of infant mortality. So there's something going on here. This isn't telling the whole picture. What we know is that we actually are one of the best countries in the world for providing high-intensity tertiary care. We're one of the best places in the world to have a heart attack and need a CABG or a coronary artery bypass graft. We're one of the best places in the world to have a 24-week baby. We're one of the worst countries in the world if we want to prevent those illnesses in the first place. And when we split out the racial statistics on infant mortality, it also tells a different story. That our infant mortality gap, the inequity in results, has actually widened. Both are going down, but if we look at the relative rate from 3 decades ago of 2.0, and now the relative rate of 2.4, with a slight increase, it's telling us something. And if we looked at black infant mortality rate as a country of itself, we would drop about 50 points, and we'd be sitting around Albania, Mexico, Moldova. And then we look at maternal mortality. So the United States is the only developed country in the entire world with a rising maternal mortality rate. That should give us pause. All of these statistics should give us pause. But again, this is not a new problem. This is also disturbing. This is the black maternal mortality rate compared to the white maternal mortality rate or rate of other races. So what are the causes? What are the causes of pregnancy-related death that we know about? And what we find here is that the traditional causes of maternal mortality rate, such as hemorrhage, infection, pulmonary embolus, cardiomyopathy, a huge section of these, and even these themselves, are based on maternal risks. So chronic conditions and cardiovascular conditions are the key drivers for all of these rates. If we look at what are the key causes of infant mortality, these rates actually haven't changed. These are the same rates and same statistics that we've had for 4 decades. It's about birth defects, and it's about preterm birth and low birth weight infants. That's what drives it. If you look at the other ones, maternal complications, all of these reflect on the left side of the graph of maternal health statistics. So thinking about preterm birth, the March of Dimes always gives off a map of how we're doing in the United States. It's great to see that Delaware is in the C category. So my state of North Carolina, we were actually in the red in the 1990s, so we've actually moved up to at least a D. But you can see that we just are not achieving what we need to be achieving. And like I said before, our direction of preterm birth, again, is going back up. So why is preterm birth so important? It's really a key concept. So one, it drives infant mortality, but it's more than that. Those babies that live also have other chronic medical conditions. There's breathing issues, feeding issues, cerebral palsy, developmental delay, vision and hearing impairments. The cost of care is driven by this. The emotional toll on families. And then we also now have data to show that even a late preterm infant, so born at 36 weeks, actually has effects later on in life. So the economic ability over the population of preterm birth is decreased. So how are we going to improve? What are the key drivers of maternal mortality? So key drivers are cardiovascular and chronic conditions of women. Key drivers of infant mortality are preterm birth and birth defects, which really are driven by the chronic conditions of women. And we've got a lot of chronic conditions. So over 43% of American women have some type of chronic condition requiring frequent monitoring or medication. We've got a lot of risks here that determine birth outcomes. So the concept of preconception health, again, not a new concept, but it is our critical concept to moving this needle. Many of the modifiable risks of adverse pregnancy outcomes, both for mom and for baby, occur before a pregnancy ever begins. So we think about birth defects, and we think about folic acid, we think about teratogenic medications, we think about control of diabetes, we think about control of high blood pressure, things like this. All of these birth defects occur oftentimes before the mother actually ever shows up for her first prenatal appointment, when we spend so much time talking about improving her health at that visit at 10 weeks, 12 weeks, 14 weeks. And we say, make sure you take your prenatal vitamins, start it now. The horse is already out of the barn. It's already too late to affect those modifiable risk factors. And now we have more data to explain this picture. So in 2010, it's a great cover article from Time magazine that talks about how the first 9 months shape the rest of your life. So this is about epigenetics and really hammers home that mother's health directly influences infants' health. And it's not just by genetics, which is what we always have thought. The epigenetics. So we have data that says mom's obesity leads to child's obesity. When we think about child obesity programs and we talk about healthy diet and exercise, the picture is bigger. It's about mom's health before pregnancy that drives some of those outcomes for children. It's the effects of toxic stress, and we'll talk about that more. So the Barker theory, people who are born low birth weight have an increased risk for heart disease, high blood pressure, stroke, and diabetes. Protecting the health and nutrition of girls and young women can prevent chronic disease in the next generation. And it's done through this epigenetics. So this is, what happens is in the presence of maternal stress, things like depression, societal stressors, leads to methylation of DNA. So it's not a change of the chromosomes, it's not an extra chromosome, it's not a genetic defect, it is a change in the expression of that DNA that then leads to different outcomes. It's not genetics, it's environment. So what are the toxic stress conditions that we've proven are related to this? So things like obesity, diabetes, heart disease, anxiety and other mood disorders, digestive issues, decreased immune responses, more likelihood of getting cancer, more likelihood of dying from cancer. And then preterm birth. We've been looking for the cause of preterm birth for a long time, and stress is one of the big ones. So thinking about this, and trying to understand what is the cause of our racial disparities, when we control for socioeconomic status, when we control for certain health behaviors, what we find is that the inequity still exists. So it's not just about health behaviors. So if we look at this, is that a black woman who does not smoke has a higher rate overall than a white woman who does smoke. A black woman who has a college education or a higher income has a worse outcome risk than a white woman who has no high school education and below the poverty line. So it seems, as I learned last night, that whiteness is a protective factor in America. So this is the data on the racial disparities, the uncomfortable truth that worse outcomes, even with control of socioeconomic status, so it's not just about poverty and education. Worse outcomes with the same risks, so it's not just about health behaviors. And that we also know is that foreign-born women of the same race have actually better outcomes in the United States, but it reverts back to the US rate in one generation. So it's not about genetics. So again, this is not a new concept, but we are talking about it more, which is really good. So in 2002, the Institute of Medicine actually came out with the report of unequal treatment, racial bias in medicine, that we found, and we've proven, that African American women and men are less likely to receive recommended interventions and treatment based on bias of their physicians in the healthcare system, even with access. So racism impacts health, and it's about toxic stress, it's about unequal treatment. So I'm not going to talk more about this because the next talk is going to be all about this, and we're going to really dive deeply with Dr. James. So what I do want to leave, though, with this topic is that it's over a life course, that our outcomes are driven before conception and are intergenerational. So if we're going to tackle this problem, we're going to need to open it wide and focus on women's health in an equitable fashion before pregnancy. So how are we going to improve? So most of our efforts over the last 4 decades to reduce maternal and infant mortality focus on prenatal and intrapartum care. So what we can see by the data is that these efforts alone, because we've done a lot, we have spent a lot, these efforts alone are not achieving the results that we're hoping for, and they often lack a racial equity lens. So the key drivers of chronic disease, birth defects, preterm birth, really have very few effective interventions in pregnancy. And the health outcomes caused by implicit bias and the stress of racism really should be considered a public health crisis. All right, so many of you may have heard about the Alliance for Innovation for Maternal Health and Intervention. So this is a collaboration of all of the specialty groups focusing on reducing maternal deaths, focusing on in-hospital care. So intrapartum, postpartum care. This is really, really important work. There's a lot of effort. Your state is among, and almost every state in the United States is a part of this. This is happening on hospital levels and systems with lots of bundles of care and standardized care and treatment. And this is really important. 50% of maternal deaths are preventable. And this is kind of like the same thing that we've been doing, is treating the symptom. This is already the outcome at the end, where the risks are already there. So I don't want to diminish this work. This is really, really important work. And we're going to have to go further upstream if we're going to change the statistic. So back to our healthcare spending, because this also doesn't tell the whole picture, and I think this is a really critical point. So as a comparison of GDP, this is what we spend on healthcare, again, compared to the rest of the countries. As a comparison, but actually if we flip it and we say, okay, wait a second, there's more to health than just healthcare. The US actually falls in the middle. We're actually not spending as much as other countries are. We're just spending it in the wrong way. We're spending our dollars on health care, hospital care, medical care. We're not spending it on the social care that we know drives outcomes. And so we have all started to really talk about social determinants of health, really understanding as a medical community that what we can provide only accounts for about 20% of outcomes. And that's where most of our dollars in spending is. So this graph is coming up more and more. This is IHI and the components of social determinants of health. You've had many lectures on this, I'm sure. You're thinking about it. And what I want to add to this is that we need to think about this in the milieu of structural racism. Because again, if we focus on social determinants of health without the lens of racial equity, we still won't get the outcomes we're looking for. All right, so what are some of the examples? What are some of the examples? So this is my clinical provider lens now of what we could be doing in the clinical sphere. So things like pregnancy intendedness, interpregnancy interval, maternal age. Some people don't think of that as a modifiable risk factor, but when we think about choices and that sometimes having pregnancies earlier in life might be healthier and less risky than later in life, especially if you have a chronic disease, having these conversations with women, it becomes a modifiable risk factor. Exposure to teratogenic medications that we prescribe, infections, substances, chronic disease control, the standard primary care list of medical conditions that we take care of women every day, and then congenital anomalies that are primarily driven by folic acid use, again, before pregnancy begins. So what are the barriers? How are we doing with preconception health? So the CDC reported last year about what are we doing in primary care. What is the receipt of preventive measures for women and men in America. And what we find is that we're doing abysmally poor. So less than half of women aged 15 to 44 received contraceptive counseling. Only 4% of men received contraceptive counseling. Less than half of women with risk were tested for chlamydia. Our unintended pregnancy rate has gone down a little bit, but it's still almost half of all pregnancies are unintended and unplanned surprises. Your Delaware unintended pregnancy rate has gone down, but it's still pretty high, so 57%. Only 1/3 of women have had preconception counseling. So all of this opportunity to counsel women about improving their health before pregnancy, only 1/3 of women actually reported receiving that. And we still have an insurance access problem. So the ACA did help us with this, all right? So nationwide, 11.7% of women still lack insurance in the reproductive age. In areas that have expanded Medicaid, that's much less. Unfortunately, though, that women who have some of the greatest risks, so below the poverty line, we still have a significant gap in insurance and access coverage. So you can be proud of yourself that your state is one of the Medicaid expansion states. That's a really positive thing. I wish my state would follow suit. We're still having struggles in that department. And I would say that part of your success has been able to do initiatives like this on a statewide level. This is your Contraceptive Access Now program, which has really shown significant improvements in unintended pregnancy rates related to access to effective birth control. So that's really a positive thing for your state, and I want to commend you for it. So what is our traditional solution to the provision of preconception care? Again, this is not a new concept. So what we want as clinicians and as healthcare systems is we want that preconception health visit. We want it designed to do this. We want to work with women who are planning a pregnancy. When a woman comes into my office and says, "Doc, I need to talk about planning my pregnancy," I kind of know what to do, mostly. But what we know is that doesn't happen. It's happened probably about 5 times in my career. We want to do it when they show up at the annual wellness visit. All right, so we're trying and making good efforts to get women in to come to their well-woman visit, and this is where we're going to do preconception health. But what we know is that this traditional approach is systematically challenged. So one is that almost half of pregnancies are unintended, so working with women who are planning a pregnancy just is not going to work. And then for the folks that do come in, only 1/3 of them actually have had a preconception care visit. So women may not even know what it is, or how to ask for it, or what the value is. So simple interventions that we know work, such as folic acid, only 2 in 5 women in America are taking it before pregnancy. We still have an access problem, 10 to 20%, so if they can't come in, they can't have preconception care. Many women miss their postpartum visit, so another opportunity missed. And then, of course, we have to recognize that U.S. women of reproductive age have more risks. All right, so another one of my favorite quotes from Don Berwick. Every system is perfectly designed to achieve exactly the results it gets. So what is our system perfectly designed to achieve? Our system is perfectly designed to achieve high costs, rising maternal mortality, poor infant mortality, and persistent and widening inequities. Our system is perfectly designed to achieve these results. So in order to get a different result, we're going to have to change the system. We're going to have to do something differently. So what is that system going to look like? So we need to have the caveats. Most women are not seeking this type of care. Many women have no insurance coverage. Most women have competing priorities for their attention, such as childcare, work, school. Almost half of all pregnancies are unintended. And then half of unintended pregnancies, we're actually using some sort of birth control, so it's not just about contraception. And then people of color experience the system differently. And so we're going to have to address that. So back in 2006, the CDC Select Panel gave some guidelines and recommendations on preconception health. So As a part of primary care visits, provide risk assessment and education and health promotion counseling to all women of childbearing age to reduce reproductive risks and improve pregnancy outcomes. And then intraconception care. Use the intraconception care period to provide additional intensive interventions to women who have had a previous pregnancy that ended in an adverse outcome. So that was 2006, it's 2019, and every year I give this talk, I have to change the date. Who is taking responsibility? So the first thing we have to recognize is that few OBGYNs actually provide primary care. So where women's health happens, often in OBGYN, preventive health, they're not the ones who are providing primary care. So, shout out for midwives. So the 10%, so less than 10% of family medicine provides OB care. And so a lot of family docs saying, well, that's an OB issue. That's a maternal child health issue. And the OBGYN says, that's a primary care issue. So what we need to recognize is that almost all primary care providers see women, including pediatricians. Women and families receive services pretty much everywhere. So specialty care, social services, WIC, child care, home health. So preconception care and the health of women should be important for all providers in all locations. This is the kind of systematic change that we need, is to take it on a community level across all groups. So the concept of every woman, every time, it's not a question of whether you provide preconception care, rather it's a question of what kind of preconception care are you providing. If you take care of women, if you see women, whatever your interaction was, and she becomes pregnant, that was a preconception care visit. So reflect upon that. What was the quality of the preconception care you provided that woman? So we see women every day in multiple settings. We need to take the opportunity when we can, when she's in front of us for whatever reason. So primary care providers really should be leaders of this effort, but all programs that serve women have a role. So we need to change our paradigm and include an equity lens, that women's health is a priority and preconception care is primary care. So what are the barriers? So this is what I hear, this is what we all say. So this is provider perception, so this is on me. This is on us in the room. So not enough time, not enough expertise, not enough resources. I don't want to ask something if I can't do anything about it. It's someone else's responsibility. I don't get paid for this. And this is one of the most dangerous ones. This is nothing new. I'm already doing it. I've always have done this. Our statistics say a different story. And then the last one is, I'm not biased. We don't have a choice. We must prioritize women, their reproductive health, and provide it differently. And we're going to have to figure out how. All right, so this is my theory to improve population health. So I believe that there's 3 legs of a stool that we need to focus on as a nation. First of all, we need to have one leg of the stool is preconception and intergenerational focus of healthcare. Put women in the center. We need to transform how we deliver health care. So we need to deliver patient-centered care differently in the office and in the community, and we need to address the social determinants of health and pay for it. And we need to dismantle racism. We need to have a racial equity lens and start to create targeted programs that reduce toxic stress. No one of these things is going to change our statistics overall. We're going to have to do all 3 of these. So a healthy woman leads to a healthier pregnancy, leads to healthier children and families, which will lead to a healthier community and a healthy nation overall. And if we do this with an equity lens, we will get a different result. It's going to take a multi-system response with the community, the clinicians, the woman, all working together to do something differently. So consumer engagement is key. So clinicians, programs, women, we're going to need to all come together. So this is the Preconception Health and Healthcare Initiatives Show Your Love campaign. It is a consumer-driven and facing initiative to engage and educate women about their health and provide resources. So showyourlovetoday.com is the resource there that has really gotten good traction and is a national initiative. The fourth trimester idea about actually providing targeted and changed care after birth, it's home at UNC Chapel Hill. It really is taking off too, and I think there's a good focus there with ACOG coming out saying that the postpartum visit is not enough. We need to do it differently. And I'm glad that Black Mamas Matter is in the house, and we're going to hear more about them later on this morning, about their raising of Black mothers' voices to change this paradigm. All right. So, what are some practical and simple clinical strategies for doing differently? So, putting back my clinician hat on, and I'm going to give you some stories. So, what we see is, from my lens, is that it's actually quite simple. It's a simple concept. Is one, we need to start including pregnancy intention screening into routine care. We need to add reproductive and preconception counseling to routine health maintenance, problem lists. And then we need to include reproductive and preconception counseling as part of the chronic disease management plan. Simple. So what does that do? When the routine screenings, when the routine care, when the chronic disease management happens, we have a different context in which to have discussions and decision making. Context matters. We need this context and we don't have it. So, a simple example of a problem list. All right, so for example, if this was my chart on a woman coming in, it would say her hypertension management, her prediabetes, her weight and that we counseled about it, her smoking and that we counseled about it, and her preconception counseling. So I document that she's not interested in pregnancy, she's taking a multivitamin, she has a progesterone implant, and when does it need to come out? That's a simple problem list. This is not something that happens routinely. A diabetes care plan. So this is in a primary care office, an endocrinology office. It could be in an emergency room. It could be in a hospital setting. So what is our A1C goal? What are the medications she's on? She's not having any complications. She's gotten her appropriate vaccines. We talked about diet and weight loss and exercise, and her reproductive preconception planning, that she has a long-acting reversible contraceptive, she's taking a multivitamin, and she actually is interested in pregnancy. And so we're going to need to have that conversation about how to have a healthy one. The simple concept of the one key question really is catching on. It's spreading like wildfire, and it's a good concept. It's not the only concept out there. So the idea of asking every woman as a vital sign, would you like to become pregnant in the next year? And there's 4 answers. And this is really critical because it's not a yes, no. It's yes, no, unsure, or I'm okay either way. And the key to this success is that this is not a judgmental question. This is a patient-centered, woman-centered conversation about how to achieve her goals. So it can tailor care to achieve her goals. But we need to be aware of the implicit bias, the ideas about who should become pregnant and when they should become pregnant. And we still have very limited evidence yet. We're trying to build the evidence of this actually improving outcomes. So the challenge is that it's been most successful in identifying women in need of contraception. It's more challenging to provide quality preconception care for women who desire pregnancy. And it's even more challenging to have the patient-centered discussion on reproductive life choices and options. So the women who say not sure, or I'm okay either way, or the women who say no, but actually probably are in the unsure or okay either way category. It does have the risk of just being another checkbox, and so we have to be aware of that and mitigate that risk. So a couple of stories about how this plays out in clinical care. So here is and these are all patients that I have seen, that I've collected, that really was like, aha, wow, this really was stark. So this is a 37-year-old woman who had no insurance coverage, so we were providing care at a free clinic in our area. She actually was there, and this was the chief complaint, is follow-up diabetes, needs refills, having diarrhea. All right, so she was recently diagnosed with diabetes. She was given appropriate treatment. She was checked on her laboratory work. And so today, she's overweight. Her blood pressure is still a little bit elevated. She's on the appropriate medication for both her blood pressure and her diabetes. She's not yet checking her sugars. And so what is the usual care for this patient? So the usual care is diabetes care. So we might adjust the metformin to reduce the diarrhea. We might increase the lisinopril to improve her blood pressure control. We might, if we're really good, give her a flu shot or a pneumonia shot. If we're really good, we would talk to maybe about her weight, and then we would say, I'll see you in 3 months. So when we ask the one key question for this patient, and the answer is, I would love to. She says, actually, I've been trying for 10 years, and I've never been able to get pregnant. But a funny thing just happened, is that since my last visit, I had my first period in a long time. And the reason is because we prescribed metformin. She had polycystic ovarian, and she was not having periods. She was not ovulating. And what did we just do? We just caused ovulation, which is great. But she's on teratogenic medications. She is on, her diabetes is not well controlled. She has all kinds of risk factors that will drive a poor birth outcome. So had we not asked the one key question, we would have done things the usual way and got the usual result. By asking the one key question, it changes everything for that visit. Here's another one. So an ER follow-up, a standard visit. So this is a 32-year-old with moderate persistent asthma. She's a smoker. She was in the emergency room for an asthma exacerbation. Her past medical history, she's bipolar, she's hypothyroid, she's got sleep apnea, and she's overweight. Her medication list, she's on prednisone and asthma medications. She's on Depakote for her bipolar. She's on thyroid supplement, all of which are well controlled. So she's feeling better. She's not quite back to her baseline. And what would our usual care in the primary care office be? We would say, okay, well, finish up your prednisone, stop smoking, see me back in 3 months. And that would be an appropriate care. If we were even better, we might make sure she's got her flu shot, her pneumonia shot. All right? So, but what if we ask the one key question? And so regardless of what her answer is, whether it's no or yes, or what we see on this med list is that she's not on a multivitamin, she's not taking any birth control, and she's on a couple of teratogenic medications, one of the worst being the Depakote, the valproic acid that causes neural tube defects. So by asking the one key question, it changes the context in how we think and counsel and educate and engage women in her own health. So here's another one that is probably really common for folks in the Title X area. So a 23-year-old presents for a pregnancy test. So this happens everywhere. It's often a nurse visit. It's negative. And we say, it's negative. And she goes home. So that's a really quick nurse visit. Often doesn't even come to the doctor. So we actually have a free pregnancy test offering. So you just come in and get a free pregnancy test and leave. So what should we do? We should ask a little more questions. And if we probed a little bit more, one is that we find that she is mid-cycle. Her last sexual intercourse was 2 days ago, and she is with a partner who often is not using condoms. She was on Depo in the past, but stopped it, so she's not on any birth control anymore. She smokes, she drinks. Otherwise, she's healthy. And she's on no medications. So now what we want to do. So one is we could just let her go, or we could actually enhance our care regardless of whether or not she wants to become pregnant. So it's like, was this a happy face, negative pregnancy test, or a sad face, negative pregnancy test? Because either one, we should be helping her to achieve her goals. There's a lot more we could do for this patient this day when she's in front of us to get a different result. So a final one in this realm of the one key question. So a 29-year-old presents for routine follow-up for her ADHD medicines. This was not my patient. So she just got put onto my list as a work-in because her primary provider was not in town, and she ran out because she was out of town for a month and missed her last appointment. So she's doing well on the medication. She's been on it for years. It helps her focus at work. She's noticed worse functioning since. There's no risk for or red flags for diversion or abuse. It was really a standard thing. This could have taken me 3 minutes. Walk in, okay, make a follow-up, here's your prescription. So when I quickly looked at her chart, though, I found a few things. So she's actually on a prenatal vitamin, which because I looked for that, I was like, wow, that's kind of cool. She's on a prenatal vitamin. Her blood pressure was up. I was thinking maybe that is related to the amphetamine that she's on, and we might need to talk about that. She actually, on her review of systems, she was having some symptoms. And her last sex was 2 days ago. Her last menstrual period was 2 weeks ago. She's had a history of some pre-E 2 years ago. When I look back, she's actually had multiple blood pressures that were elevated. And because we asked the one key question, she actually said, yes, I am. I'm trying to become pregnant. So all of a sudden, the alarms go off in my mind, is that everything in red here is a risk factor and a danger for a poor birth outcome. The medication she's taking, the blood pressure uncontrolled, her weight. She's actually having some symptoms of cardiovascular disease. Remember, the driver for maternal mortality is cardiovascular illness and chronic disease. She actually could be pregnant today because she just had sex. And she's got a significant risk history. So when I asked her, it's like, you want to become pregnant, and there's a lot of risks here, she actually broke down and cried. She said, no one has ever asked me that before. I want to become pregnant, and now you're telling me that I have all of these things that are going to put this at risk. And why hasn't anyone talked to me about this before? So now we've got a lot of problem. I mean, this 3-minute visit turned into a 45-minute. Was it the right thing to do? Yes. So just putting that into context, so I counseled her about her risks. We actually got a pregnancy test. We did some lab tests to look at her heart and her risk factors. I offered her emergency contraception. She declined. She says, nope, it's already out. If it happens, it happens. I'm okay with it. She decided to not take the Adderall. She chose abstinence until she could figure this out and talk to her partner and make a plan about blood pressure and work on diet and exercise. She continued her prenatal vitamin, and she came back in 2 to 3 weeks to further follow up. This is the kind of care that women deserve. This is what we need to do differently. So the key concept is by asking the one key question, missed opportunities for improved reproductive health care are uncovered, and medical management can change significantly. So another way of doing things. So the Implicit Network that was mentioned earlier is that we're a group of family medicine and pediatric residency programs and academic health centers and FQHCs providing intraconception care to mothers at well child visits. Women come in a lot, not necessarily for their own health, but for the health of their children. So this is a great opportunity to provide some discussion around her health. What we do is that we focus on 4 behavioral risks affecting future birth outcomes: smoking, depression, family planning, and birth spacing, and multivitamin and folic acid use at well child visits. So we repeatedly screen from birth to 2, we assess, we reinforce, we connect, we collect and analyze data to improve our strategies. So if anybody's interested in this, it's a free download of the toolkit from the March of Dimes. So some of those stories, again, just driving home kind of the key concept here is here's a mother with type 1 diabetes at a 6-month well child visit. So when we ask those questions, she's not on contraception. She had sex 2 days ago. She's not on multivitamins. She actually was discharged from her primary care provider. She wasn't our patient for financial reasons. And her diabetes is out of control because taking care of a newborn is really hard. What we were able to do is connect her. She became a patient of our practice. We gave her emergency contraception, started on birth control pills to bridge her to the next visit. We averted the care. We averted the risk for this patient. How much did we get paid for this visit? 0. How much cost to the system we just saved from a NICU stay, from a maternal complication of an uncontrolled type 1 diabetic? A lot. All right. So in the interest of time, I'm going to go to it. So the key concept of what we found in the Implicit is that frequent, consistent messaging of certain preconception healthcare issues seems to have made a difference in our population. Women are more informed. They're taking multivitamins. They're coming in with more intentionality to their pregnancies. The Women's Preventive Services Initiative, sponsored by ACOG and HRSA, really is meant to define what preventative services women need. They've actually designed a new tool for us to have that has gone off of the Bright Futures checklist for children. So this is a helpful strategy. What we need to do, though, is that screening and how we screen matters. These are all the types of screening that women need on a regular basis, and there is a lot. There's a lot of screening that we should be doing, and that can become overwhelming. Some of these have actual evidence-based tools to use, questionnaires, and then interventions to do. If we tried to bundle all of these together, it becomes overwhelming and probably less helpful. So the preconception coin, in which your state is involved, is trying to redesign how we screen and engage women in their health care around preventive health. So we want to create a women-centered, clinician-engaged, community-involved approach to the Well Woman visit. We don't know what the right answer is, but we do know we need to do something differently. The challenge with screening questions is that many evidence-based screening questionnaires exist, and there's no evidence of what happens when we bundle it all together. What we do know is that there is question fatigue. There is a concern about what are you going to do with this information. You're asking me all these questions, but you actually don't do anything with it. It's just checking a box. You're just getting paid for your quality measure. You actually don't really care. So I'm just going to answer no to everything. So what we did at our institution as part of this coin is that we did a human-centered design approach. We got clinicians, we got patients, the staff together, and we tried to redesign the process. We created an engagement tool. We created a package screening tool to try to engage women as why are we asking the questions, why is it important, and we need your help. We need you, the woman, help in deciding what priorities are there. We acknowledge the responses. We use the tools to engage. And our key concept is needing to say, I hear you. So our key finding with human-centered design for improving women's health was the critical importance of trust and relationship and time to talk. This trust needs to go in all directions, the patient to provider, provider to patient, patient to healthcare system to patient. The Patient Advocacy Foundation, I took a picture of this slide because it means so much. If we had this sign in every clinician's office, you are your own primary care provider 99.9% of the time. So how can I help you take care of you? If we took this approach and had the context, we might get different results. So your state has really been a forerunner on this. So your Healthy Woman, Healthy Baby initiatives and now your 2.0 opportunity to really engage equity and social determinants of health, I'm really looking to you to see what you can do differently and get different results. Focus on the 3 legs of the stool, because our future depends on it. Thank you.